this next talk is one of my favorite topics, and I can tell you one of my most unfavorite patients is that patient who has critically severe cord compression. They come into my office and they have a little bit of neck pain. They don't really have myelopathic symptoms, and they go, "I'm told that my spinal cord looks like a ribbon, and I need an operation next week because if I trip on the sidewalk, I'm going to be paralyzed." The reason I don't like that patient is because I end up not operating on that patient, but also because now I got to spend 30 minutes explaining to them why they're not going to be paralyzed and why they don't have to have surgery next week. And I'm ultimately not going to operate on them. So it becomes a challenging clinic visit. So asymptomatic cord compression has always been interesting to me. And I think spine surgeons approach this very differently. And I'm going to have Dr. Cha kind of talk about his approach to patients that have severe cord compression. So Tom is the director of the MGH Spine Surgery Fellowship Program. He's assistant professor at Harvard, and he's an assistant chief of orthopedic spine at Mass General. Tom and I did residency together. Is an extremely technically gifted, very thoughtful surgeon, and is kind of teaching the up and coming best and brightest. So Tom, you'll take it away and let us know how you're looking at patients that have asymptomatic cord compression.
Thanks, Brian, and really thanks for the invitation. You've put together, as you said, a couple of thought-provoking topics, and it's definitely something that I'm learning from just attending and listening to everyone else speak as well. So thanks for doing that. So going to the talk here, my disclosures. And here is a scenario, like Brian said. I mean, this is probably once a clinic or once every other clinic that you have a patient. Maybe they hit their head on something, or have a little neck pain, or had imaging for another reason about their neck or their head, and they come in. You see this critical amount of stenosis. You see the cord getting compressed, and you examine this patient thoroughly, and you ask a detailed, nuanced history, and you don't get anything, and it really becomes sort of a conundrum, and it's going to pretty much take up a full 20-30 minutes to have this conversation and lay out the pros and cons. Because in our head as surgeons, we know we could make this MRI look like the one on the left. We could make it look like the one on the right. And it probably helps, us maybe more than the patient sometimes sleep at night, knowing that we have this spinal cord decompressed. Because unfortunately, we've seen the bad things that can happen when this goes unnoticed. But to get there, we have to go through this, right? We have to go through general anesthesia. We have to go through surgery and its inherent risks that it entails. So, this is what's going on. You're just weighing the risks versus the rewards. And you're generally having to go with which way the scales are tipping. So how do we think about surgery? How do we think about not doing surgery? How do we keep the score here? And generally, it's the modified JOA score. So it's a scale from 0 to 18, 0 being the worst, 18 being the best, but made up of motor function of the upper extremity, the lower extremity, sensory function of the upper extremities, and then sphincter dysfunction scores. And it's important to keep in mind this is the modified JOA, because the original JOA, being from Japan, included use of chopsticks as how to find the function of the upper extremity. So keep that in mind sometimes when you're seeing studies out of Asia. So let's talk about the reward side first of the surgery. These are the results of a multi-center AO-funded prospective study looking at the efficacy and safety of surgical decompression. And what you can see is they stratified the groups based on MJOA scores preoperatively into mild, moderate, and severe cases, and saw how what the effect of surgery was. And across the board, there's improvement in functional and quality of life outcomes across each of the 3 severity groups. Regardless of the severity, that outcome change was pretty consistent, except for the change in the modified JOA score for postoperative follow-up at 1 year. this did differ among the severity groups. So the worse the severity of the disease on presentation, the greater the improvement, right? So that's the ceiling effect that we see. If you start off with mild disease, there isn't really that much more that you can impart on the patient in terms of improvement with the surgical decompression. This question was also looked at really only one time in a prospective randomized fashion, and this is the Kadanka study from 2000. Looking at, this is just a milder group of myelopathic patients. Their JOA scores were all above 12. But looking at operative versus non-operative treatment out to 10 years. And interestingly, across this group, there was really no significant difference in functional score change between the non-operative and the operative group, which does fly a little in the face of a whole host of other studies observationally that show really the positive impact that myelopathy surgery can have. But perhaps this just shows even more that in that mild group of myelopathic patients on presentation, there really isn't that much to improve. So it's difficult to show any sort of significant difference. So, what else, how do we do this? Like in other areas of orthopedics, we try to think of what all the imaging parameters that we could see with this really strong, powerful MRI picture of the inside of a patient's spinal canal, and try to use that to predict, what's going to happen to that patient, both functionally and in the future. And there's all types of measurement parameters, and they've all been looked at. So in terms of the cervical spinal canal, in terms of the cervical spinal cord, there's lots of different ways to look at and things to measure. And when you look at the different ways to view what's the average AP canal diameter, you see that the canal is quite capacious up at the C2-3 level, but then as you move down the subaxial cervical spine, it becomes smaller in consistency at about that 15 millimeter diameter. However, probably what's more relevant for cord compression is understanding what is the soft tissue canal diameter, because there's other things that fill the canal besides just the bony diameter. And when you look at that, those numbers get a little bit smaller. Again, up at C2, it's quite larger, about 14 millimeters, and then it gets to about that 11 to 12 number in the subaxial cervical spine. And then when you look at the cord diameter itself, that generally is a consistent number at about 7 to 8 millimeters, and that's the same width generally all the way from the upper cervical spine down to the lower cervical spine. Now, here's an X-ray on the right, and you see this in clinic, and you see this decrease in that spinal laminar line on the lateral, and you're probably seeing a patient that has congenital stenosis. Sometimes it feels like, in spine clinic that everyone has this, but it probably is only present in less than 10% of the population, but it's something to keep in mind. And the way I think about it is like this paper nicely points out that you sort of have this normal distribution of what the cord diameter might be, and you have a sort of normalish distribution of what the canal diameter might be. And you get into sort of this place where they overlap, where you have a cord that's really not big enough for the, a canal that's not big enough for the cord that you normally have. You just basically lose any wiggle room and margin for error for either subsequent degenerative changes or response and capacity if there's a trauma. We have to remember that life does not happen statically supine like on an MRI, but there is physiologic movement of the neck. It's quite mobile, and physiologic extension even will narrow the canal just from disc bulging and ligamentum flavel infolding. And then when you talk about pathologic motion, so if this is a study looking at biofidelic cadavers, but looking at in a whiplash, in an impact of 6.5 grams on the C5-6 canal diameter, that could essentially create a decrease in about 3.5 millimeters at that level. So when you think, if we think about that patient that might have congenital stenosis or might have significant cord compression, another 3.5 millimeters of narrowing during a whiplash injury could result in essentially 50 up to 50% cord compression and a real ding on the cord there, which we know from animal studies, which we know from trauma and spinal cord injuries, is sometimes all you need to lead to significant and permanent dysfunction and impairment. So you really, again, get back to this decision point. Is the reward greater than the risk? Maybe it is in this case on the left. Is the risk maybe greater than the reward? Maybe that's the case of this patient on the right. So every patient, of course, is different in an individual situation. So what do we know? I mean, these truly asymptomatic patients that present with cervical cord compression, what happens to them? Can we do anything to inform our decision making about how to follow these patients and counsel them? And just before I go through the study, I do want to say it is quite uncommon to see someone, I think, that has truly asymptomatic cord compression. The nature of the symptoms and the disease itself can be subtle. The physical exam is, quite important, and also some of those findings can generally be operator dependent. So you almost have to sniff out sometimes myelopathic signs and symptoms, and really make sure it's something that you do yourself before you call someone truly asymptomatic. I also would consider if they have a radiculopathy, so not myelopathy, but a radiculopathy, since we know that is something that is prognostic for the development of subsequent myelopathy. I would consider that a symptomatic patient and not sort of in this bucket of patients as we go through this area of literature. So, the truly asymptomatic patient with spinal cord compression radiographically, what do we know about them? And from this cohort study out of Czechoslovakia that followed patients like this, 8% of this group of 66 patients developed myelopathy at 12 months. And then a follow-up study later in the same group of patients, that number jumped up to 22.6% at about 3.5 years. So there is a rate that patients can develop myelopathy, although you see them at first that they are asymptomatic. And then this is really, the thing you worry about in the back of your head. And, sometimes another surgeon sort of tells them, if you're in a car accident, you could end up being paralyzed, or you take a bad fall down a set of stairs. And you sort of have to talk and walk that patient sort of back off the cliff sometimes when you're going through this. And I find this kind of really interesting because it's really, everyone views statistics in different ways, and you could really use statistics kind of to your advantage or disadvantage many times. But I thought this was a nice study that, this is out of Japan, a population-based study, and they measured the risk of cervical spinal stenosis and spinal cord injury after trauma. And when you look at a car accident or significant trauma leading generally to presentation at a trauma center, this is something that happens at a rate in this population of 33 people per 1 million. Okay, and then when you look at those 33 that are in these type of accidents, when they present with a spinal cord injury, that's again an even smaller segment of those 33 people. And then lastly, when you look at those folks that have developed spinal cord injuries in these traumatic events, if they had a pre-existing cervical spinal stenosis or whether they had a normal sized canal, you interestingly see two things, and these are both sort of true statements. Number one, the folks with the pre-existing spinal cervical stenosis, they had 125 times higher rate of developing spinal cord injury after a traumatic event than the patient that had a normal canal. So that sounds terrible. That sounds super scary. But when you look at look at the probabilities, and right, so these type of things, this is mathematics, right? Multiple probabilities that have to happen in sequence, right? You multiply them, and what you see is that really this is an absolute risk event of 0.0017. So that's a super small number, and that's something that's really what, when you sort of say to yourself, okay, what would happen if you were in a car accident? What how would that kind of look for you since you're asymptomatic now? That's the number I think you got to really go on in terms of something that you could prevent with essentially a prophylactic surgery. So again, back to this decision point. On the risk side, right, now from that same study, that AO multi-center study, you could see that there was an overall complication rate in all these surgical patients of about 18%. So 52 patients had 78 complications, with the two most common complications being dysphagia and infection. But the complication rate did not differ between myelopathy severity groups. So, the complications weren't just much more prevalent in the severe group of patients. This was in the severe, moderate, and mild. So sort of across the board, it's just something inherent to the surgeries themselves. And this rate was in the smaller study at Toronto as well. Similar, types of complications, and these rates sort of ranged from 0.52 to 6%. So ultimately, when you come down to the scales and which way the scales are tipping, and you're thinking about, okay, you have a potential downside of presenting as a spinal cord injury, right? And we could think about, yes, maybe they develop myelopathy in the future, 1 year, 2 year, 3 years down the road, but it's going to go at a slow pace. It's going to be mild myelopathy upon presentation. It's the traumatic spinal cord injury presentation that you really want to avoid here, and you weigh that against the risk of the complications of surgery. I think it's pretty significantly in favor of not doing surgery on these folks. And that's been confirmed in the development of a clinical practice guideline, again, sponsored by the AO Spine Society. Essentially, this was 5 systematic reviews looking at certain questions. And one of the questions being the topic of this exact talk. So non-myelopathic patients without symptoms of radiculopathy, not offering prophylactic surgery for these non-myelopathic patients. These patients should be counseled, with the risks of the progression, and educated about the relevant signs and symptoms of myelopathy, and followed clinically. So this is something that you could follow. This is something that you can speak to and have the patient involved in this shared decision-making process. Thanks very much.
Tom, I love that talk. I'm going to jump right to some questions here in the interest of time, because I do have a few questions, and I'm going to hopefully be allowed to start my video in a second. So my first question is, my experience is that spinal cord compression can actually cause neck pain. And that is because I have seen patients that were decompressed with pretty severe stenosis, and their neck pain gets better. And these weren't even fusion patients. These may be laminoplasty patients, ACDF patients, whatever it is. So I do think there's a component of neck pain to cord compression. So even though neck pain is not part of the MJOA, does that factor into your decision-making at all when someone goes, I just have unrelenting 10 out of 10 neck pain? Maybe you do an epidural and it helped them temporarily. Maybe you ruled out facets, you ruled out the discs. Is there ever a point where you're operating for neck pain in the setting of cord compression?
Yeah, no, I'd be hard pressed to say that. I would say, there's like different types of neck pain, right? So there's like the C4 radiculopathy that kind of looks like the neck pain, and generally you can kind of tease that out. I think also too, there's that, group of patients with cervical spondylosis that present, I mean, they have cervicogenic headaches. So we know that there is probably some kind of connection there to, some sort of axial areas where pain might present. But I think, when you looked at the, the disc replacement studies versus the ACDFs, and you saw like cervicogenic headache, when you asked about it, it can improve. But I think it doesn't improve, unfortunately, at a reliable enough rate that if that were the sole, indication that you could, reliably relieve that.
And let me ask you about cord edema. Somebody comes in 50% compressed cord from a soft disc. There's signal in the cord, but they're pretty asymptomatic. Does cord signal drive your decision making at all?
It's one of those things where you find studies on both sides of the fence about that. And intuitively, it's like, how can it not, right? I mean, it's a pretty remarkable finding. So I think it does sort of, push you, lean you sort of one way more than the other. But I honestly can't say that it is sort of like in and of itself. Again, like I think it's one of like the softer things that might sort of, be the tiebreaker, if you will, but not sort of in and of itself. I think, you can watch those.
In North America, our criteria for calling someone myelopathic is kind of wild, right? Like you read some of these notes, like it'll be like, patient is, severely myelopathic. They have some difficulty with fine motor skills and balance. But when we really administrate the MJOA, they're like a mild. Yeah. Because a severe is like you literally can't walk and you can't feed yourself, yeah. Which is almost never the case in North America. Do you give patients with cord compression that have these kind of very mild symptoms any chance at conservative care? Somebody has maybe a little bit of numbness in the hands and fine motor skills. They're also 70 or 80 years old, but they have no other symptoms. But you're pretty convinced that this is from the myelopathy. Yeah. Are you operating on those people? Are you giving them a chance at conservative care? What do you think?
Yeah. Well, I think also too, it's that milder group of patients. I mean, again, Scandinavia, God bless Scandinavia for these like long-term follow-ups with like but like, that there was that study looking at them, out to, over 5 to 8 years, and the mild patients like did not progress. I mean, so it is. I think it's a function sometimes of like when does that clock start? I think probably there's a preponderance of like MRI, and we sort of know about these things earlier maybe than other kind of places. So yes, I think it is reasonable, like especially mild symptoms, that you can watch it, because when it does develop, we always kind of the Leeson Turner, it's that stepwise, but that curve like is a little bit more like this. Like as you're mild, you progress very mildly, but then when you start going on the wrong side of the slope, then things kind of the wheels fall off. But milds you can watch. There's time.
And the clinical literature really suggests that if you catch the progression within 6 months, it's somewhat reversible, actually, in terms of
right. So the improvements are still that you see. That time scale is probably on years, not necessarily like months of pre-existing.
Bobby and Adam, what are you telling patients if there's cord edema, no cord edema, some pain, but maybe a little bit of mild myelopathy, maybe not? What's your general algorithm for that? We could start with Bobby, since he's first on my screen.
Usually if they have just mild symptoms, I give them the option of just waiting it out and following them, over time, like a yearly visit, and just giving them opportunity to have access to see us if they start to have progression. So there's a lot of counseling of the patient on what to look for on progression of disease, and also to make sure that they're careful not to participate in high risk activities like that would, like rugby or something like that, right? Something that they would potentially have their neck twisted in a bad position. Although and I tried to dissuade. I tried like you. I always get these patients that always get told that they're going to be paralyzed immediately once they've been diagnosed with cervical myelopathy or cervical stenosis, and I always tell them, you probably have had this for probably about the last 7 or 8 years, and you've done just fine. You're not paralyzed yet. So why do you think you're going to be paralyzed in the next 24 to 48 hours, right? It's a interesting topic, to say the least. So I've lost track of what your question was now.
No, that's the perfect answer. You basically said, I do what Tom does.
Yeah.
Adam, what do you think? What do you do?
I'll take a little bit of a different pathway. I think that it's interesting. It can impact your practice a little bit. I've had patients, say, for example, neurologists send me patients, they were seeing them for headaches and they got an MRI of their neck. They have stenosis, they send it. I mean, I've had it out with a couple of neurologists that say, I'm not sending you anything anymore. This patient has severe stenosis. I said, they're not myelopathic. They're pretty asymptomatic from their neck. And furthermore, I think that you can often come off as cavalier. They've seen a couple other spine surgeons that say you absolutely need to have this treated as soon as possible. And I kind of shrug. I get a MJOA on patients. They look normal. They examine normal. I say, this is real. I use it as an opportunity as a practice builder. I start off with 6 months, and then once they're okay at a year, I do annually. So again, that's just more stating the landscape of spine care, and how sometimes when you do your best to take care of patients you feel like it's the right way and the way you'd like your family to be taken care of, it can have consequences that scramble your head a little bit. And you're like, well, hold on, why are you upset at me for saying, you don't need a surgery immediately? But I agree with all you guys. I would take it one step further. I take care of 2 Division I college athletics programs, and try cervical stenosis in elite college football player that's going to the pros. I mean, you want to talk. I mean, thankfully, I get along with Bob Watkins. I mean, he's been my lifeline to say, like, hey, I showed it to him. But again, that's not the topic, but that's like another layer. This guy runs a 4.25 40, and he had a TQ, or he had like some neck pain. He's got bad stenosis. You're like, ugh, geez. I mean, that right there, you want to talk about hours and hours of your life right there eaten up. But I watch stenosis all the time. I examine them. I tell them what to look for. And I say, I didn't even see Tom's talk before, but I say, you know what? There's 2 different risks: paralysis or decline with an accident or waiting, or the risks of surgery. And the data says that the risks of surgery in asymptomatic stenosis or mild myelopathy is greater than that of living your life. If you're doing fine, live your life. We'll watch it. We'll take it seriously. I don't know. Sometimes I think in this panel, it's a reasonable thing to say, but sometimes you get together with some other spine surgeons, they think we're all crazy.
Well, I think the purpose of this symposium is to talk about the things that we kind of all see, and to try to see what kind of the thought leaders are doing and what they're thinking. And hopefully, spine surgeons that watch this, you just have a different view on things. The last thing I want to ask you, Tom, is you mentioned radiculopathy in the setting of cord compression, right? Radiculopathy is also not a component of the MJOA, but we do know that radiculopathy kind of portends what may happen with the cord. So are you saying that if somebody has a C7 radic, but they have cord compression as well, that you would treat the radic kind of independently of the cord, or would you do both? Meaning, would you still do conservative care for the radic, or would you say, because you have a radic and you have cord compression, you need an operation? And the second part to that question is, if you do decide they need surgery, are you treating just the radic component? For example, somebody that has tight congenital stenosis C3 to 7, but they have a soft disc. Could you do a foraminotomy or an ICDF, or are you going to have this person get a PCF or a plasty plus the foraminotomy because you want to treat the cord compression, even though they're not actually myelopathic, they just have the radic?
Yeah. So the first part of your question, yes, radiculopathy does portend onset of myelopathy and then worsening of myelopathy as well. So that's been shown and that's known. So yes, that would sort of change the conversation about treatment. That ramps it up to, this is a kind of a mild / moderate myelopathy, and then take it even a step further in terms of treatment. So yes, when you are then treating that, I would take that opportunity to decompress all parts of the cord. I mean, sort of, I think of it like kind of analogous to like when patients present with claudication, like you have to decompress, everywhere where you think that dural sac is compressed, right? So similar type of thing here. When you have significant cord compression radiographically only, but then presenting with radiculopathy, I think you have to be sort of over decompressing, if you will.
Do you give that radic patient an initial presentation a chance at conservative care, or do you think you just say, you know what, you got cord compression, you got a radic?
Assign that also a checkbox into the myelopathy.
If your radic gets better, what do you do?
Well, that's tough. Yeah, I know. That's tough. But generally, again, it's the radiculopathy is kind of like the first straw, if you will. So generally, like you're not going to see that situation. But
what do you do with radic and myelopathy? Are you radic with asymptomatic cord compression?
I've actually done just treatment of the radic with like posterior base.
I know you have. That's why I asked that.
Yeah, and I've had patients do quite well from that. So
hold on, we're all agreeing so well before. What happened?
What happened?
I'm an outlier. You have to be very careful though. You have to watch the blood pressure and all that.
Yeah, right.
I usually use monitoring for those particular patients, which I don't typically do for just my basic foraminotomies. So I've decompressed them, and I've had pretty good results. I haven't had anybody luckily, knock on wood, I haven't had anybody had neurologic deficit afterwards, from cord ischemia. And I do sit them up for my foraminotomy, so that actually makes it potentially a little bit worse from a cord perfusion standpoint.
Yeah, right. Adam, what do you do? Radic with asymptomatic cord compression.
It's a number of segments phenomenon. I think that the problem that I have, if it's all contiguous, I usually just treat it, 3-level anterior occupying lesions, disc osteophytes, gets a 3-level ACD for unilateral radic. Once it starts skipping or you get 4 segments, it's funny, there's all these like little weird things, right? Like I just saw a guy that had a acute 7-1 disc, cord signal change, but severe 3/4 stenosis. I'm like, ugh, what do you do with that? I just did the acute disc and left the other severe stenosis because I said, well, that's what's new, instead of doing I hate PCFs, like doing a 2-to-2. That's like the classic surgery that I think all does crummy. But I tend to treat the stenosis at all levels if it's contiguous and reasonable, 2 or 3 level ACDF. I think once it gets multi-segment and needs something more, I've not been overly successful with plasty plus foraminotomy. I know, Brian, you and I talk about this a lot. Like sometimes just when you do a plasty, the cord decompression kind of helps things enough that the arm pain seems to get better. It's probably a controversial take, but by the time you do your trough, open your door, and then you're doing a foraminotomy and put your plate on, you're looking at it, you're like, geez, there's not even that much left. Again, we're getting in like the detailed nuances of what we do. That's probably a lot of words for not even saying what I do. But I've done both. I mean, I think you look at the patient, you look at their age, you look at their expectations. We all have this weird algorithm that we all kind of equate to, but I've gone both ways. And heck, I've given them an epidural and their arm pain gets better, and I watch their asymptomatic stenosis, right? I mean,
I've given old myelopathic patients a central epi, and their myelopathy got better. I swear to God.
I have a question for the group, actually. What do you do about the patient who's got asymptomatic, moderate to severe cervical stenosis, and you're about to do a lumbar surgery on them? That's not small. It's not a microdiscectomy. It's more like a 3-level fusion, right? Something that might have some moderate blood loss, might take more than an hour. It might take like maybe 3 or 4 hours to do. How aggressive do you treat that cervical stenosis? Do you treat it at the same time?
I think if it's lumbar predominant, I just like you said, your cervical foraminotomies with stenosis, I'll monitor those patients just to make sure I don't put their neck in a bad position for 3 or 4 hours. But if I think it's lumbar claudication predominant, I'll do their lumbar spine and watch their neck. Some people are the other way. They say you got severe stenosis, you need the neck to be done first. I mean, first of all, we all like doing neck surgery, right? So it's like a quick way to get a neck surgery out of it. But I've had a bunch of bad cervical stenosis that I've watched and done their lumbar spine, monitored them because it makes me feel better. I've thankfully never had an intraoperative alert in that instance. Sometimes you catch it on the back end. People wake up with some hand numbness and you think, oh, is it a positional neuropathy? It's not getting better. Maybe that you image their neck and you go, oof, they've got some bad cervical stenosis. And then you watch them. I mean, it can be
those
tricky.
Situations. Do you ever protect their neck by putting them in tongs so that anesthesiologists can't?
I still use a prone view and just do it myself and make sure they're neutral. The prone view, you can kind of dial a position. So I try to get them neutral.
I think it depends if they're truly asymptomatic. I think I put them through a range of motion in clinic. I have them like hyperextend for like 5 minutes and see symptoms. I have them go down and I'm paranoid about the positioning, but I monitor those patients. I don't put them in tongs. I would not treat the neck if they're asymptomatic. I just watch them, make sure they have good extension and flexion. And sometimes they don't even do a fiber optic intubation. I think the cord is a lot more resilient than I think we often think. And particularly with spondylosis, where the cord compression is slow and gradual, it's not acute like a soft disc. I think that cord has some plasticity. And if your maps are like 80 to 90 during the lumbar case, which sucks because they're bleeding the whole time. But, I would do the lumbar without issue. What do you think, Tom?
Yeah, same thing. I think you're fine to do the lumbar first. Obviously be mindful and monitor as needed, but I think it'd be fine to do the lumbar first.
Or you do them at the same time.
Yeah, that's the other thing, right?
Maybe out in California.
Cervical laminoplasty with tongs and a lumbar 1 to 3 fusion.
Yeah.
I actually have my fellow do the lumbar case while I'm up doing the cervical case. It's twice as fast.
All right, guys, listen, we're an hour over, but I forget how much I miss like conferences and just talking to people about spine surgery. I have a great junior partner, but it's like I just forget how much I miss talking about topics that I don't want to say they're controversial, but just debatable, and seeing what everyone else is doing and hearing what the thought leaders out there are doing. So I can't thank you guys enough for doing this and taking the time to do it. California Orthopedic Association definitely thanks you. And I know we have some some SAE questions, right, that you guys all wrote. So I think that'll conclude this symposium, and hopefully people paid attention and learned something. But thanks so much for doing this, guys.